We have been having these workshops for a long time, and I welcome you all for this edition under the aegis of Microneurosurgery workshop. Dr. Datta is also very well experienced in all endoscopic procedures and has been holding, and he will be the main anchor for the day. He will be guiding you at the till the evening. So we will try and keep our lectures short so that we finish them early, and then after the hands-on demo by the experts, you will have the stage or the cadavers for yourself for the whole day, and I want you to make best use of them so that you understand the anatomy, because I understand most of you are at the basic level to understand the anatomy, and those who have already been doing endoscopic surgery for a long time, they can explore the more advanced teachings which will be done in the morning. Thank you. Good morning to all of you. I think those were excellent talks. And what I will be telling you is about skull base repair. So, it's been almost 50 years, half a century since pituitary or endoscopic surgery was started. And we have really advanced in that almost half a century that we've been doing it. However, as a surgeon, if you are not able to manage the complications, then obviously we will be not as good as other people or other specialties like ENT who are there and who have been doing it before us. So, the most important complication we all know is CSF leak. And although we may admit it or not, some of us say that they don't have any CSF leak, but the fact is everyone has CSF leak. And as our approaches are becoming more and more extended and radical, the chances of CSF leak is also increasing. One more thing which I would like to point out is that even the smallest pituitary tumor or cellular approach can have a major CSF. It can still have a high pressure leak, and that is not dependent just on the pathology but on other factors also. So Hadad actually revolutionized, this was in 2006, just around 15 years from now or 10 years from now that this paper was published by Hadad himself, and this revolutionized how we repair the skull base. And when I started my endoscopic journey around 10 years back, first thing I started doing, I was doing Hadad flap for each and every patient, even the smallest pituitary, just so that I could learn how to create a Hadad flap. That is very important, so that when the actual complications are at that time, you're not learning how to make a Hadad flap. So I would make the flap and put it back, because in small pituitary you don't require it. But it is important that you start learning it right from your first surgery itself. How you make it, where is the lines, how you, as Dr. Suri showed and everybody else showed, how is it that you create the flap. When you start doing the flap, you will find that it becomes very narrow because you've made mistakes, you've not gone down inferiorly to the base to create a wider flap, or it's not long enough. So this, over the next 5-10 flaps, you will become better at it. And once you are good at creating a Hadad flap, then your confidence level for surgery also improves. However, there are disadvantages of the Hadad flap also. There is in the literature, there is a necrosis rate. And as neurosurgeons, one of the disadvantages we face is that we do not see our patients in the OPD where we can see the nasal crusting and other problems. ENT surgeons do that, but we don't. And that is a big problem for us, because all these patients will have nasal issues after surgery, which we somehow just ignore. In fact, up to 15% of the patients will have septal perforations or collapse of the nasal dorsum, which is a very big complication. So even the smallest surgery can lead to major complication. You have to be careful how you raise the flap, and that is why I say you start right at the beginning. Hadad flap is as good or as important as approach to sella. We talked about these various techniques, and gasket seal technique is there, bilever button technique is there, all there in the literature, you can look it up. But why do we have so many techniques? Why do we have Hadad flap? Why? And as Dr. Suri said, small pituitaries may not require anything. You don't require a flap, just a fat will do. So the problem is when I come to the reasons, we have so many options. We have dural substitute suturing also people are doing, and as Dr. Suri also said, Japanese surgeons did. Even in India, we have from various institutes, PGI, they are trying suturing it and showing it. However, it's a difficult, technically demanding, I would say, surgery. And the reason behind all this is this CSF leak grading. So we have grade 0 where there is no leak, grade 1 where there is a low flow leak. So low flow leak means it is not coming out pulsatile with like a jet in every arterial pulsation, and a high flow leak is grade 2 and 3. And when you look at this slide, you will see that 25% of the patients which we operate have high flow leak. It is not that they will have low flow leak. 25%, only a small percentage 10% will have intraoperative low flow leak. And as you see the leak, the kind of repair increases, I would say, disproportionately. This is grade 3 high flow leak. People try everything and anything possible in the armamentarium because as you become more experienced, you understand how devastating a leak can be, which you are not able to control post-operatively. So you try everything intraoperative, and in a grade 0 where there is no leak, still you will put in fat, still you will put in glue, because you don't know if the post-op suddenly, because patient coughs or something happens, leak may develop, which may in fact convert to a high flow leak. So people have also tried Foley's catheter when there's a high flow leak to buttress whatever you are doing inside. And there are inflatable Mirocells also available where you put in the Mirocell and inflate it also. This is all, again and again I am saying, this is all there because the complication CSF leak in itself is not a problem, but if it develops meningitis, you have infection happening, and it doesn't happen immediately, in the sense you have it after 1 day, 2 days, you may discharge the patient comes back in emergency. That is not uncommon. After 1 week, after 2 weeks, and at that time you again go back control, but infection has set in, so many complications. So these are patients who are absolutely all right, walking, talking, now coming back with meningitis, moribund, devastation for the patient, for the family, for you. So there many, as I said, it has been there for half a century, so people also have been trying to control this situation for half a century. And there is a devices also available. One is this clip device, and this is by Medtronic, and they actually, it is a U-clip. This commercially available where you can apply it and it sutures semi-automatically. Again, it is technically demanding. Then what I found was there's an umbrella technique. In fact, this is a very interesting device. This is a Amplatzer occluder by Abbott, and it is for the cardiologists. They put it for ventricular septal defects. So this device, actually this is the cartoon. You imagine we have entered the cellar here, and we just entered the dura. You put in this device and it expands, and then on the facing your aspect side, it doubles, so it compresses. So beautiful version, and it is actually, the cadaveric studies have been done, though no clinical, people must be using it, but there are no clinical studies on it. So cadaveric studies in the pituitary cellar floor, they have tried, and they found it very useful. The size is also very nice. You get it for 2 centimeters or 1 centimeter dia, and it is obviously, it's available commercially in India. It's around 30 to 50,000 rupees. So when we talk about the price versus the quality and where we are in terms of CSF defects, it's very difficult. There are no, I would say, devices available besides all these buttress techniques that we are, and that's why we were looking around, and what we devised our own technique, and this was using the mini plate. I think this is easily the beauty of this technique. It is easily available in every institution. We use it for fix the cranium or to do other things, and that is why we explored the possibility of using it to fix or to add on to whatever other methods we were using. So this is a short video where I'll show you. So this was a case which had been operated outside. residual large pituitary. They had already done endoscopic, and you can see the big defect we have. We have taken out the pituitary, residual pituitary, and as usual we put in the fat and then the gel foam, and still the defect is very wide. Then I introduce my mini plate, and you see this is a 6-hole mini plate. 6-hole means the defect must be at least 4 centimeters. And the advantage is with the standard mini plate, standard everything screwdriver, you can just put it at any bony point where you know obviously that the carotid is not there, and you just fix it. So here we are putting it in. You can see how wide the cavity is because of the previous surgery, and this is when I say it's maximally destructive. You know, the whole nasal cavity, recurrent pituitary you operate, you will get to know how big and how destructive it is. Even in the smallest, the whole thing becomes a big cavity. And this is, we have done no extended, simple pituitary people have done, and they've removed everything around. So here I have put in the screw, and after putting in the screw, the mini plate, we just put in a fascia. We are just, you might call it a overkill, but there is nothing like overkill when you're trying to prevent a leak. So I put in a layer of fascia. You don't need to put the other screw on the other side, just one screw on one side, because the fundamental physiology of preventing a high flow leak is to prevent the pulsations or dampening the pulsation. It's like a growing skull fracture, same pathophysiology. And then I just put another mini plate, and I put it across both sides, fashion it so that, and then finally I have my I put my glue, and I have my Hadad flap as usual, the last, I would say, wall against all this, and we put in the Hadad flap over this after another layer of fascia. So I always cover the mini plates also, so it's not exposed, and this is the Hadad flap now coming on, and so it's completely dampened. What happens if you don't have a dampener like this mini plate or any other instrument? Because of the pulsatile thing, it will continue to push it, and the high flow leak especially, there are very high chances despite your best maneuvers. And I said that was 25%. So this is just a 3D view showing the mini plates in this. So it is a very easy technique, 100% available, and screw is extremely low profile, already available. They are self-tappable, so everything is very easy. You should think about it, keep it in an armamentarium. And we have done around 11 patients, all of them which we've had intraop CSF leak. And obviously, we were lucky, we still haven't got any leak in these patients. So I would say understand and learn the complications, and the most important complication. The second is obviously carotid or arterial injury, which also you should learn to understand if you have an endovascular surgeon standby where they can coil it, how to control the situation. And this is the far more common complication which we should all know. Thank you so much.